Recently here in the UK, our BBC documentary raised concerns that the high-profile menopause specialist Dr Louise Newson may have been prescribing excessively high doses of hormone replacement therapy treatments at her clinics. Newson Health denies any wrongdoing, but as you can imagine, the documentary sparked a debate in this country, with some menopause campaigners saying that the programme was a setback that could deter women from seeking HRT. Others, including Dr Philippa Kay, who's written a book called The Science of Menopause, and she's appeared on this channel, I'll link it below. We discussed HRT safety, and she says it's time to call out what she describes as an over-medicalisation of the menopause. Clearly, it's a hot topic around the world right now, and there are strong feelings on either side. So to give us a balanced and informed view, I turn to the respected British Menopause Society accredited specialist, Dr Naomi Potter, who herself has a considerable following on social media, and she's also the founder and director of the Menopause Care Clinic. Dr Naomi co-authored the best-selling book Menopausing with the TV presenter Davina McCall as a guide for women to help them make informed decisions about how they navigate the menopause. And in today's conversation, we'll briefly go right back to basics at the start to make sure we're all up to speed with the three main hormones affected by menopause and how they're affected, the major forms of HRT and the prescribing guidelines, before I pose some of those tougher questions such as, could all women benefit from HRT at some point in their life? And is overprescribing something we should be worried about? And if so, why? And what are the kind of conversations doctors should be having with us to help us make those decisions? Dr Naomi, great to have you here. The menopause is a bit of a minefield for those of us going through it. So I'm just very glad that there's brilliant experts like you around to help steer us through it. That's what we need.
Oh, thank you. Thank you.
I thought it would be helpful just to go back to basics actually, and then just start with what the perimenopause is versus actual menopause in terms of the hormones that are affected and the extent to which they're affected over those transitions.
So the perimenopause is the time leading up to the menopause, which is your last period. And the perimenopause is really signified by hormonal turbulence. So you still have hormones and you can easily still have cycles, but there is a lot of underlying hormones just literally going a little bit bonkers. So your estrogen levels can be a bit all over the place, for example. Progesterone levels tend to be lower. Whereas in the menopause, your ovaries are really not working at all. So there's not much, or if any, hormonal production. So the menopause diagnosis is what we call a retrospective diagnosis. So you only know you're in menopause 12 months after your last period. But whereas the perimenopause can go on, for years whilst your ovaries are in declining function.
Okay, so for a doctor to confirm that you are in menopause, you cannot have had a period for 12 months, basically.
That's correct. But also you can't have had additional hormones, because if you're given additional hormones as a part of HRT, that will mask what's going on. So you need to be 12 months period free, not on HRT, for that diagnosis to be made based on your periods.
And I mean, once we've reached menopause, what has actually happened to our hormones? Which are the hormones that are affected? And I mean, to what extent are they wiped out? I mean, what extent are they affected?
So pretty much estrogen and progesterone are wiped out. So the vast majority of your estrogen comes from your ovaries, and the ovaries they no longer work when you're in menopause. And if you scan postmenopausal women, sometimes their ovaries are so small you just can't even find them, because they what you call atrophy, so they just shrink away because they're not active tissue. So it's estrogen. In perimenopause, it's turbulent, and then that tails off postmenopause. Progesterone also tails off, but it tails off. You produce progesterone every time you have an ovulation. So if you don't have an ovulation, you don't produce progesterone. And that's one of the markers when we look for fertility, for example, whether somebody's ovulated or not. So because the ovaries have anovulatory cycles, so cycles where an egg is not produced, much more in perimenopause, that hormone also diminishes. And testosterone is another hormone that declines with age. It doesn't kind of fall off a cliff like estrogen does after the menopause. It's a more of a gradual decline with every decade of life.
And beyond our reproductive health, what do those hormones do for us? Because I suppose this is part of the debate that we're going to come on to about, why we may want to keep those hormones going. So why are they good for us?
So estrogen in particular, we know quite a lot about its function, and it seems to play a role in the functioning of so many, or practically all, of our body organs and tissues. So we know that we have receptors on practically every organ system for estrogen, and without that estrogen, those organ systems sometimes notice the decrease, and that's why we get symptoms. So not every woman will experience symptoms, but it's why there are so many different symptoms, and why they vary and they come and go, and they can affect so many women in so many different ways.
Yeah, because I mean, people talk about heart health, brain health, and so on being linked to estrogen. Or does it really play that big a role, do you think, in our overall health? Because you wonder why on earth, through evolution, has this hormone been wiped out?
Well, if you look at life expectancy graphs over the last few centuries, and so really, since human beings have been around, we know that life expectancy has extended massively since the early to mid 1900s. So before 1900, the average life expectancy was about 41, even less than that as we go back in time. So it was really only in the 20th century that this has been a significant issue, because it's really since the 1930s, 40s, 50s that women have significantly lived into their menopausal years. So that's why it's not really, it's probably not an evolutionary phenomenon. There are hypotheses that postulate that it might be, because menopause is seen in some but very few other animals. But it may well be that this is just what happens, that ovaries have a life expectancy that is independent of their host, so independent of the body that they're in.
Do we know why some women are so badly affected in menopause and seem to have just an awful time versus other women who seem to sail through it?
We don't really understand the science behind that, and it can be so cruel, because some women really do sail through without as much of a symptom, except that their periods stop, whereas others have such a terrible time. And it can be independent, and certainly lifestyle can play a part, but you can have women who have exemplary lifestyles and they still experience really severe symptoms. So we don't know that at this point.
That was going to be my next question, actually, was lifestyle and just how big a difference that makes. Because anecdotally, in fact, I spoke to a fitness influencer really recently who commented that she sailed through the menopause, and she's only just started HRT now in her early 60s because of the health benefits, but she didn't need it during menopause. And that is something anecdotally I've picked up on from very fit women. They seem to be more likely to kind of get away with its worst effects. Does exercise in itself have that big an impact?
I think it has a significant impact that varies from individual to individual. So some of the symptoms that menopause can bring, so fatigue, poor sleep, night sweats, feeling low, feeling anxious, can all prevent you from exercising. So you can end up with a bit of negative feedback. So you then don't exercise, so you feel even worse. Whether, if you're somebody that has always exercised, whether that protects you from menopause symptoms, it may well do. We know that exercise is protective for so many different things. It certainly can make you feel better, especially if you're outside, you're in nature, you're in fresh air, you get vitamin D. So there are so many reasons why exercise may well do that. But we don't really know whether, if you're fit before you go into menopause, you're less likely to have specific symptoms than if not.
Are you aware of any data around different types of exercise and menopause symptoms, or is that just simply not been explored?
Well, different types of exercise can do different things. So, for example, a lot of my patients are now talking about cold water swimming as a way of not necessarily, well, it can help you get fit, certainly, but in terms of the mental health benefits from participating in that, I mean, that can be hugely beneficial. Into cardiovascular exercise, we know helps with cardiovascular health. Strength training exercises, we know help with muscles and joints and bones. So every type of exercise can have its own specific benefits.
I can imagine the mental health benefits of cold water swimming, because I tried swimming with my sister in, I think it was Highgate Pond or
Oh,
something, a couple
yes,
of years
yes.
back. I was so glad to be alive when I got out of it. A big mental health benefit.
It really, I mean, so many people now are talking about it as really from for mental health benefits, and it really does seem to make a
I
difference.
mean, most of us are aware of the most common menopause symptoms. So I'm thinking of the hot flushes, night sweats, brain fog, things like headache and mood change, anxiety. Actually, I'm no stranger to that. And I think that has possibly worsened in the last couple of years. But what are some of the less commonly known symptoms that patients tell you about?
We see patients coming to clinic who have been referred to so many different specialties because their symptoms haven't been identified as menopause. So I think there's some of the musculoskeletal symptoms in particular, so things like plantar fasciitis, which is quite a specific type of foot pain that
Ooh,
you wouldn't necessarily think was anything to do with menopause at all.
no.
Frozen shoulders, again, you see far more in this kind of age bracket or demographic.
Okay.
Tennis elbow, that's another musculoskeletal symptom that is associated with menopause. Things to do with eyes and ears and mouth that you wouldn't think was anything related. So dry eyes, sometimes even watery eyes that you can get as a rebound. Tinnitus, itchy ears, and then dental problems, burning mouth. I mean, there are so many. There are
Wow.
so many. That's just scratching the surface.
Are there any ways that you look at that you can sort of differentiate, well, what's hormonal and what's not?
It's really hard.
Mm,
It is really hard, and it's especially hard. So in the UK for what we call GPs, so family
mm,
practitioners, where you have about 7 or 10 minutes with a patient who comes in with different symptoms that you might have to piece together and identify as menopause when it's perfectly feasible that it's not, but it's just having that menopause radar on. And if you've got somebody with new symptoms that they've never had anything related in the past, particularly like mood symptoms, so you've got
mm.
somebody with no mental health history and then all of a sudden they've got anxiety and low mood, you've got to think, could this be hormonal? And then if something doesn't respond in the way you expect it to, then that's another reason to think, could this be hormones? But it's just having that awareness that hormones are so important. They play a role in practically everything.
And I mean, you mentioned some of the muscular problems there. I mean, I'm thinking of my poor sister-in-law with her frozen shoulder and tinnitus, and I'm thinking, gosh, is that what's up there? Why is that the fall in estrogen that is affecting the muscles in that way then?
Estrogen keeps tissues working well, and that's the most likely explanation. It's a bit like WD-40. It just kind of keeps things supple and lubricated and moving well. And without it, then certain systems just are a bit squeaky and they don't work as well.
I now use an estrogen gel, but the thing that drove me to that, the most curious symptom ever, was that I was having night hallucinations, I would call them. So falling asleep and then waking up, sort of opening my eyes, something would wake me up. I would open my eyes and I would see spiders coming down from the ceiling. Or in one case, my poor husband sleeping next to me would hear me shouting out the most bizarre things. So I would suddenly shout, "It's a bent nail!" And there would be like a kind of bent nail scratching at me above my head. And
Wow.
it was like seconds, but I would wake up and get a flash of something. And it really, I just thought, this is hormonal related. It just came from nowhere. Have you heard of that kind of thing?
Impact on sleep and what happens in those dark hours is actually fairly common. I mean, that seeing kind of those specific images, I haven't heard that description before, but certainly kind of waking up and not knowing why you've woken up, then not getting back to sleep, feeling very discombobulated in the middle of the night, feelings of things kind of coming over you in the night, particularly feelings of panic, like sheer terror kind of rising up from
Yeah.
your lower body and kind of sweeping over you. Those I hear about quite a lot. But nothing. I mean, it does sound hormonal. It's just a slightly unique twist on something that is.
Trust me. Trust me to come up with something absolutely bizarre. But yeah, it stopped. It stopped. As soon as I tried the estrogen gel, it just stopped. So I thought, well, that must be, I'm not completely going mad.
But that's one of the other symptoms, isn't it? Am I going mad?
Yeah.
So if somebody comes in, in their 40s or 50s, particularly for women in their 40s or 50s, and they just say, "I don't feel myself. I feel like I'm going mad," that's a classic symptom.
Yeah, it reminds me of a friend. The other evening, we were just chatting, and we were talking about HRT. She's my age, and she said, "Well, I don't think I need it," but I noticed that she was looking really down. She wasn't her bright, sparky self, and she said, "The only thing is, I feel that I'm much more emotional than usual." And she said that something at work had made her cry, which had never happened before. And then she said she woke up at 2 a.m. crying. She'd been crying in her sleep about it. She thought, this is really unlike me. It's that kind of thing, isn't it?
Yeah.
Just all of a sudden it creeps up on you, and you think, this isn't right. This has come from nowhere, and I'm not quite myself.
Absolutely. Yeah. And it can be really hard to recognize in yourself as well, because, you're in yourself the whole time, and life happens, things happen that are, as that are bad or difficult or challenging. And it can be hard to tease out what's normal life and what would be an appropriate response to something negative, and what's not your typical response to something like that, to a challenge.
My husband has said he's noticed me at times like just more tense than usual, more reactive, a little bit more uptight, tightly wound than I would have been. And you think, yeah, possibly. However, it could just be me. Younger woman, because, for some women, this hits really quite young. What are some of the telltale signs for younger women? Is it just the disrupted periods, or can your periods be absolutely regular, but hormones are at play at a younger age, thinking sort of late 30s, early 40s, into the 40s? What are some of the signs they can look for?
Yeah, we see plenty of women in their late 30s and early 40s with perimenopausal symptoms. You can continue to have regular cycles. The symptoms can be fairly typical. You can get hot flushes and night sweats, but they can be atypical as well. Mood changes can be one. PMS, worsening PMS. I think you probably see more of that in that category of patient.
So premenstrual syndrome, do they call it?
Yes. Yeah. So for 2 weeks of the month, they feel fine. And then for 2 weeks of the month, they absolutely don't. And then their period will start, and then they feel better again. And they kind of question whether they'd experienced those last 2 weeks or not. So that can be a symptom, but it's not something that should be ignored. So if you are young and you are questioning whether it's perimenopause or not, these are the women that we absolutely need to treat. They're the women that need estrogen replacement unless there's a contraindication for bone and cardiovascular protection. So it's often we often see patients who've come to us being told that they're too young for HRT. There is no too young for HRT. If they need it, they absolutely must have access to it.
One of the complicating factors there, I mean, I have a lot of viewers in the States and from other countries, and their experience may be different, and probably will be, because they'll often be going to specialists. But here, as you pointed out, we've got these general practitioners. And I mean, my experience of going to a GP is that they'll say, well, we can't test you because your hormone levels fluctuate. So they're kind of just going off what you're telling them. And it's quite a strange situation, really, because you don't know where you are in terms of being perimenopausal. Or, you know, in my case, I have a coil and I have I use estrogen gel. I have no idea where I am.
Yeah.
I could be through the menopause. I couldn't tell you. So, I mean, for younger people going, or from women of menopausal age turning up without the testing, what do you make of that? I mean, how can you tell where you actually are without the testing? Should we all be being tested?
The very short answer to that is no. You don't need to, and
Okay.
the test results can be misleading and falsely reassuring, or the opposite. They can be useful in excluding other conditions. So if you have younger women, particularly, or older women, but where the picture is you're a little bit unsure, could something else be going on? Then testing is absolutely, you would look for lots of other underlying causes. So you look at things like full blood count, thyroid function, vitamin D, B12, folate, liver function tests, kidney function, and then depending on what you find, you can look further. So you can kind of exclude other conditions. In younger women, it's also nice to have a diagnosis. If you've got somebody else, particularly under the age of 40, you want to know, if you possibly can, if they are menopausal. And then there are hormone tests that you can do. But if you get a normal result to those hormone tests, it doesn't necessarily mean that you are not perimenopausal. So that's the danger of doing those tests. You don't want the false reassurance. No, you're fine. You know, it's not hormonal. It's something else.
Yeah.
When those results can be normal, and that using hormone replacement can make a difference. You can't really start HRT too young, because you're not going to do any harm apart from maybe a bit of disruption of a normal menstrual cycle. You might get some bleeding or a few side effects, but you're not going to do harm by trying it. So if you had somebody that you were suspicious with, it was an early menopause, blood results were all normal, you have a trial of HRT, if somebody gets better, then the chances are you've cracked it, you've found your diagnosis. If it doesn't make the slightest bit of difference, it's probably not, if you've really explored all the available HRT options.
I mean, now coming on to the big question, do you think that all women could benefit from HRT at some point?
It's a really tricky one. I think there is a potential for benefit from HRT, but using HRT is such an individualized decision and care plan, for want of better words. It's not without hassle. So there are side effects. There's bleeding. You have breast tenderness. You have nausea. It needs frequent monitoring. You have to go to see your doctor. You have to obtain prescriptions. You've got to use it. So it's not. I don't think it's a yes, every woman should be on HRT. I think every woman should be given the opportunity to discuss it for them. And if they want to try it and they are aware of the benefits and the risks, then they should be allowed to. So I don't think it should ever be withheld. But I do think it can be very nuanced and it's very individualized. And some women won't take a paracetamol for a headache because they don't want to do anything that is any sort of intervention, in which case those are often the women that just don't want to take HRT. And that is absolutely fine. But equally, if you've got a woman that wants HRT, then they should be offered it after a discussion about the benefits that would be available to them.
Yeah, because the other tricky side of it is then when you stop, and if you stop, because there are a lot of women who say they are going to take it for the rest of their life. I suppose there is a movement now towards HRT and almost it being a right, for women, and a right for women to keep taking it as long as they wish. Do you take any view on that?
I definitely feel like women have a right to autonomy over their own body. And I don't feel like any professional should withhold something that a woman wants if she's understood the implications from taking it. So I don't believe that any woman should have their HRT stopped after 55 or 60, or because they've had HRT for 5 years, or any other reason. I believe that women are very clever. They understand. They understand, and if they want to remain on HRT, then I think that they should be allowed to make that decision for themselves.
Does it give them a health advantage? Do we know that yet? Because we
We
probably
don't know
haven't
that.
had
We
these.
don't know that yet. We don't have that. We don't have that data. We know that it certainly helps protect bones. So from osteoporosis to the thinning of bones, and that's very important. It's if you have a fracture of your hip, in later years, then you have a 30% chance of dying from that within a year. So that is a significant risk, and you have that when you are osteoporotic. So we want to make sure that women don't have osteoporosis, and it's also cardioprotective. So we know that it protects the blood vessels of the heart and the circulatory system, and that the leading cause of death for women is heart disease. So we know that there are potentially lots of advantages, but we don't have data to say that if you are on HRT for the rest of your life, you are more likely to live a long, healthy life than for those women that don't. We don't have that yet. I suspect that in our lifetime, then we will have much more information on that going forwards.
And that will be a fascinating comparison and really crucial information for women. There has been in the UK a very high profile documentary recently questioning at least one menopause clinic over the amount of HRT it was prescribing to patients. And the inference was that HRT was being overprescribed in too high doses, so unnecessarily prescribed at too high doses. I mean, what was your reaction to the suggestion from that documentary?
I mean, I'm a believer that if there is a question regarding clinical care, then the appropriate channels should be followed or pursued in order to identify whether there is a misprescribing or inappropriate prescribing happening. I can tell you what we do in our clinic. We're the biggest group of British Menopause Society accredited specialists in the country, and we prescribe according to guidelines and according to our levels of expertise. And on occasion, there might well be an indication to prescribe off license or off label, where you might prescribe higher than necessary doses of estrogen, particularly. And sometimes you need to do that in order to help the patient and to have the patient experience a kind of symptom-free living. So I think that is the kind of important message, is that there are sometimes situations whereby it is necessary as specialists, and you just need to make sure that you counsel patients, you tell them about the risks and the benefits and what we know and what we don't know, most importantly. And then patients can make that decision themselves as to whether they want to take take their advice and use that prescription.
I mean, why might some women need higher doses than others?
It's like any medication. So some people respond very quickly to lower doses, and some need higher doses. But as well as the kind of symptom relief from specific doses, when we talk about estrogen replacement, we're often referring to transdermal, so estrogen through the skin. And women seem to absorb estrogen through the skin very differently. So you might have two women who look very similar. They might be the same height, the same weight, the same skin type, and you can still see really significant differences in how much they seem to absorb for symptom relief. And we sometimes look at blood levels. If you've got somebody who, despite using the maximum licensed dose, is still completely symptomatic, you would question, well, are they absorbing? And then you would look at their bloods to see whether their estrogen levels were non-existent. So we don't really understand why some women just don't seem to absorb as well as others, but that does seem to be a phenomenon.
And what is the maximum dose that is licensed?
So it's different for different products, but for the main products in the UK, so we have the patches where it's 100 micrograms. The estrogel that you were talking about earlier, where it's 4 pumps, and there's a Lenzetto spray where it's 3 sprays. But women absorb different products differently. And the Lenzetto spray is actually much less strong than we used to think it was. So 3 sprays of Lenzetto is probably only the equivalent of about 2 pumps of gel. But yet 4 pumps of gel is licensed. So it's all very new. It's very nuanced. It's not easy. It
Yeah.
is not easy.
And so you're largely really going off a woman's response and how she feels in response, or how they feel in response to the hormones that they're taking. But you would do blood serum checks where they're at very high levels, just to make sure that they're not too high blood serum levels.
Almost the opposite. So if you had somebody, so say you were prescribing somebody the estrogen patch, and by 100, they were still they still had their hot flushes and the night sweats. At that point, I would do bloods to see whether they had any estrogen that showed up on their blood level.
Yeah.
And if their estrogen was very low or undetectable, it makes you question whether they're absorbed. Well, they're not absorbing it. That's the kind of situation that bloods can be useful. And after kind of careful counselling, you might consider going above the manufacturer's license. But you would have a clear conversation with the patient every time you prescribe and say, you understand that you're above the manufacturer's license. We don't have data for women who are on higher than the manufacturer's license over the years to look at the safety of it. Does that make sense?
Yeah, it does. I'm just wondering what a concerning situation would look like to you in terms of someone being given too much HRT.
So what we see is there's a lot of, because there's so much information and quite a lot of misinformation out there. Some women who are desperate to take control of their symptoms, they sometimes self-prescribe, they sometimes take the advice of their friends or the advice of the internet, and they will increase their dosage without really understanding the ramifications, because there's a lot of word that you can take as much estrogen as you need, which is not strictly true. So that's when it can be potentially very harmful, especially because the higher the dose of estrogen, the more progesterone you should be taking in order to protect your endometrium. And that's the other conversation that you have with patients about if they're on the higher doses of estrogen.
And so that really should be balanced, because a previous discussion I've had on this channel was with a couple of aesthetic doctors, actually, around the trend of women applying estrogen cream to their face because it was like the latest wrinkle treatment. And they were kind of saying, look, don't do that, because these things need to be in balance and against your own health profile and your hormonal profile as well. So I'm guessing you would probably agree with that don't run out and slap the estrogen creams on your face without looking at the full picture for you.
So these are prescription only medicines for a reason. They're hormones. And so if you have women using them of their own accord for indications that your prescriber might not even know about it, that's when things become dangerous. And that's why we have prescribing guidance and guidelines. So your prescription should only be used for what they are prescribed for. And anything that you're thinking about using them for, you should discuss with your doctor before doing that, because there are lots of implications of using prescribed medications in ways that they're not designed for.
Lastly, I wanted to touch on testosterone, because it's not something that we think about in relation to women, but you mentioned there at the start in that profile of hormones that tend to decline with age, as everything does, unfortunately. What role does it play for us, and when might be helpful to look at replacing it?
Testosterone is very misunderstood. So we have some data about its function in the female body, but not a huge amount. We've actually become more conservative in guidance in the last year about when it should be prescribed. So currently, the prescribing guidance is that you should consider testosterone replacement in women who are adequately estrogen replaced already. So they're on HRT, but they continue to have a distressingly low libido.
Right.
And proof that they have low testosterone levels.
Okay, so you would measure that. You would do a blood test for that one.
You would do a blood test in advance. It's fraught with difficulty in interpretation because libido is it's an emotion. It's almost a psychological phenomenon. And though it's very unusual to have an isolated low libido in somebody that is otherwise feeling absolutely fine. So it can be very hard to extrapolate out. And
I just actually assumed that libido was something that generally did wane with age. Maybe that's just me again.
well, libido is so multifactorial. Yes, libido does tend to decrease with age, but it also decreases with length of time in a relationship. It decreases with other stressful life events, which tend to increase as time goes on. So there's so many different factors that influence it.
Yeah.
And that's why it's so hard to identify and to know when to treat if you're treating according to guidance.
Yes.
If you ask me whether I thought that it had greater implications in the things that it's sometimes advertised to do, so mood, cognition, strength, I think with some really robust randomized clinical trials with big numbers, I think there is a good chance that it will. I think if you see men who have their testosterone shut off chemically, then they don't just lose their libido. They experience lots of other symptoms. And we know that testosterone is a drug of abuse in sports. It helps with performance. And so it would make sense that if you replace testosterone, it might make you feel better and stronger and faster and more powerful. But we don't know that at normal female physiological levels kind of categorically at the moment. So it's really tricky, really tricky.
Yeah, and that really is one to watch then from a health perspective. Again, just getting some large-scale, robust trials, as you say, to tell us, is this something we could benefit from actually supplementing with in later life to give us additional benefits?
Yeah. I hope it would be amazing to get some really good, strong data soon. It really would.
Thank you so much for sparing the time and just filling in some blanks on information there. I'm sure a lot of people will find that useful. Thank you.
A pleasure. Thank you.
So some difficult questions for Dr. Naomi there, and I think she did a great job to give us balanced responses based on the current evidence. And I'm going to link to her book and to her Instagram page below, both very much worth checking out. Also below, you're going to find links to my website, honest.scot, where I explore more around how to age well. There's also a sign-up page for my free monthly newsletter so you don't miss any content from me. Plus, there's links to my social pages and podcast options for listening to the Honest channel on the go. And to make sure you spot my weekly episodes, then just hit subscribe or follow if you're on a podcast platform, and that will make them easier to find each week. But for now, thank you for being here today.